Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on consent. I hope you enjoy it. Welcome to today's podcast, and it's all about consent. My name is Dr. Sam King, and I'm a medico-legal consultant with MPS, and I'm joined today by two of my colleagues, Dr. Lucy Gibbard and Dr. Tim Cookson. Thanks for joining me today, you guys.
Thanks for asking us.
Pleasure, Sam.
So today we're looking at consent, and this first case that I want to discuss is explicit consent for every little thing, ? As proceduralists, you might have a good understanding of consent, and today we're going to discuss an HDC case looking at this very question. And this case involves a gynecologist who performed a minor procedure on a patient which was not specified in the consent. The gynecologist proposed to examine the woman's urethra and bladder under general anaesthetic, and if indicated, perform surgery on her anterior vagina. The consent form stated EUA, cystoscopy, inject local anaesthetic, /steroid, query, refashion anterior vagina. There was a standard clause on the DHB consent form stating, I understand that procedures additional to that specified above may be carried out if it is in my best interests and can be justified for medical reasons. During the procedure, the gynecologist noted some adhesions of the posterior vagina and decided to free those adhesions, which might help to alleviate the patient's symptoms. But only surgery of the anterior vagina had been specifically consented for. In making the decision to proceed or not, the surgeon took several factors into consideration. The patient had earlier had more extensive surgery, and that was some months prior. This was in the patient's best interest to free up the posterior vaginal wall, and it would remove the need for another operation and GA. It was only a minor variation to the consent. And not only that, the standard clause set in the DHB's form covered this variation. So just thinking about these things, Lucy, I'm going to ask you, do you think it was reasonable for the surgeon to proceed under the circumstances?
Well, look, I can understand why he did. And I think that standard clause in the DHB consent form probably led him astray because it probably gave him the impression that he could carry out procedures beyond what is on the consent form if it was in the patient's best interests. Whereas I think, in fact, if we were to look at the Code of Rights, we would decide that actually that was wrong and that actually a clinician shouldn't be doing any surgery beyond what is specified on the consent form, even if it is in the patient's best interests, unless it is in an emergency. So I think the answer is no, it wasn't reasonable, but the poor surgeon was misled by his DHB's own consent form, which made it look like it could have been.
And the other factor too is that the consent form is not actually the real consent. The real consent takes place in the discussion between the surgeon and the patient as to what's going to happen. And to be informed, a patient has to have had that discussion, and then ideally that should be documented carefully by the surgeon. So in this case, if the surgeon had said, look, you've had previous surgery, there may be some adhesions there. If I see some adhesions around the uterus that I think releasing them might be beneficial for you, would you be okay for me to go ahead? So even if it's not specifically written on the form, if it's discussed and recorded in the notes, then actually I think he would have been fine.
Yes, I think it was a little problematic that he wrote specifically anterior vagina. But as you say, if he'd consented more broadly for any possibility and included, posterior, just the word posterior, that obviously would have caught and would have been caught up all right in the consent form, and he could have proceeded quite safely.
I do think that clause in the consent form that the DHB had written was very misleading, and I think it probably misled him to make him think that actually he could carry out additional procedures in the patient's best interests. And I think that, one of the learnings from this is actually that the DHB shouldn't have that kind of clause in their consent form, because actually you can't just paternalistically decide that something's in the patient's best interest and carry on.
And proceed.
You actually need the patient's consent for anything apart from a true emergency. I think we can all agree that if there had been an emergency situation and the patient had a condition that may have been threatening to their life or to their long-term health, and he had proceeded with additional procedures, then that may have been more easily justifiable. Whereas in this situation, I don't think releasing those adhesions was an emergency. And actually, as far as the Code of Rights concerned and informed consent, I think the right thing to do would have been to wake the patient up and say, I found some additional adhesions. I think we need to do some more surgery. Now, from a clinician's point of view, that may seem nonsensical when actually it's a simple thing to do at the time. But actually, from the consent point of view, I think that's really important.
Certainly the surgeon had every good intention. You're right.
Absolutely.
If you think about the public system and the pressure on it, it would have taken months and months for her to come back onto the list to be able to have the minor procedure done. And while he was right there, it was relatively minor, so it seemed very expedient and very practical. He just took the practical route. But I would agree, Lucy, that according to the code, it's not right to have done that.
So, Lucy, coming back to your point about the emergency situation, does that need to be specified on the form, on the consent form, do you think?
I think it would be helpful, actually. Maybe that they could change that clause to say, I understand that emergency procedures, additionals of the specified, may be carried out, to make it clear to patients that in an emergency. But actually, I think that the doctrine of necessity would probably allow you to do an emergency procedure to save someone's life, even with nothing written on the consent form.
Yeah, but it's certainly going to be better for the patient and everyone if there's some kind of warning that if there's an emergency take place, major blood vessel is damaged or whatever, then you need to take whatever steps you can to save the patient's life. Yeah.
I think one of the issues with this case as well is the outcome. I think that we often, even if you're doing something in someone's best interest, you don't always know what the outcome's going to be, and that it's so easy to be criticised actually when the outcome isn't good if the consent process hasn't been perfect. And often that's what the HDC ends up concentrating on, because they can't really complain about an outcome, but people can definitely complain about the consent process. And I think you were saying that a significant number of HDC cases are about consent.
That's right. We were listening to Morag McDowell, the new commissioner, and she said that 15% of their cases are around consent. It's obviously a big issue. But also, as you know, when there's a poor outcome or an outcome for a patient that was unexpected, that fell below their expectations, usually they will complain about consent because that's the process which often isn't very well documented, is open to arguing about. And so patients do raise issues about consent. Interestingly, about that catch-all phrase that the DHB had on their consent form, the Commissioner considered that the standard clause on the DHB consent form had the potential to confuse or mislead the surgeons about the situations in which they could deviate from a consumer's express consent. And so obviously, the Commissioner is in agreement with you, Lucy, around that.
That's good.
Pleased about that, aren't we?
Pleased about that. I mean, the other really ironic thing here is that there may be another patient who would have actually complained if the surgeon hadn't proceeded, and that the patient had been woken up and said, actually, we found some more adhesions. We're going to put you back on the waiting list to do a posterior vaginal operation. A second patient may have complained and said, well, why didn't you do it while you were there? So it does feel a little bit like the surgeon was in a bit of a no-win situation, but it's just so much easier to defend the doctor who doesn't do a procedure that's not consented and the patient complains, than the doctor does do a procedure that hasn't been consented and then the patient complains.
I agree. And most patients would have been grateful, wouldn't they? They would have woken up and thought, that's great, you've done that, I don't have to come back, it's and we'll carry on and everyone's happy.
And that's likely to be the case so long as there aren't any adverse effects of that additional procedure. Yeah.
Well, let me just tell you what the patient had stated to the HDC, that following this procedure, the patient complained that she had not consented to the procedure, that she had required more time off to recover than she had planned, and had not prepared herself psychologically for the more extensive surgery. She had ongoing pain following the operation, which she felt had been worsened by the procedure. So even though from a purely medical point of view, everything was probably fine, the reality is that for some reason it was a big deal to her psychologically, and she'd already made plans around her time off work and whatever else she was doing in her life, and therefore it was really not the right procedure for her to have had at that time.
The other irony here, of course, is that we will never actually know whether the additional procedure did actually cause her to take more time off or to have additional pain.
No, that's true. That's true.
A complete unknown. But because she was unhappy at the end of the procedure and the outcome, then, as you say, she's going to go looking for things that she can complain about.
No, that's right. So the Commissioner had this to say: the gynaecologist did not have consent to undertake the procedure and reiterated that surgical services may be provided to a competent adult in non-emergency situations only if that patient makes an informed choice and gives informed consent, irrespective of what the doctor considers to be in the patient's best interests. So the learning point from this case is that even an operation of a minor nature, and it being very practical and expedient to proceed without full consent, that it's actually hazardous to do so. So if you're going to do that, you do proceed at your peril. So let's now look at our second case about consent, and I've titled this "Forewarned is Forearmed." So this case relates to the care provided to a woman who underwent a mesh procedure in 2017 to treat stress urinary incontinence. At the time of the surgery, the significant risks of mesh surgery weren't known. So 5 months prior to the planned operation, the surgeon, who we're going to call Dr. Clark, discussed the option of using mesh, and Mrs. Atkins signed the consent form. Dr. Clark documented in the consent form that he discussed with Mrs. Atkins the following risks of the procedure: infection, bleeding, perforation of adjacent organ, and that's all. Aside from some conservative therapy discussed, Dr. C did not document having discussed with Mrs. Atkins any non-surgical options or surgical options not involving surgical mesh. Dr. Clark told the HDC that he would have provided the patient with an information sheet on stress incontinence and this particular sling procedure, because that was his usual practice. Unfortunately, he didn't document this. The information sheet also lists other risks, which includes difficulty passing urine, the sling exposure, urgency and urgent continence, and pain. So the information sheet did, in fact, provide more information. We're not sure, of course, whether Dr. Clark went through all of those extra potential risks, but they're definitely documented in the information sheet. The DHB told the HDC that the process of exchanging information with Mrs. Atkins and obtaining her informed consent for treatment began when she was first seen 3 years prior, when various options for managing her incontinence were discussed with her, and she elected to manage her symptoms conservatively and with physiotherapy. The DHB said that when Mrs. Atkins was seen by Dr. Clark, her options were discussed again, and this time she opted to have this particular mesh procedure. The DHB considered that Mrs. Atkins was given more than adequate time to reflect upon her decision to progress with surgery in light of her worsening incontinence in the more than 4 months between her being booked and the procedure taking place. So in this particular case, so even though Dr. Clark hadn't gone through the any other possible options other than the mesh surgery with the patient, because of the process of time, she had in fact tried a great number of other possibilities in terms of conservative management. So eventually Mrs. Atkins comes up for surgery. And 1 hour prior to the surgery, a different consultant, Dr. Donaldson, met with Mrs. Atkins to discuss the surgery. Dr. Donaldson documented having discussed additional possible complications of surgery with the patient and updated the consent form to reflect what they had discussed. Dr. Donaldson had documented that Mrs. Atkins was happy with the discussion of the risks and benefits and that they were to proceed to theatre. Later, Dr. Donaldson told the HDC that he recalls that the patient already had a good understanding of both the procedure and the associated risks, and he was satisfied that Mrs. Atkins had provided informed consent. Dr. Donaldson also stated that if on the day of the procedure he has any doubts that a consumer is not fully informed or has any hesitation about proceeding, he will postpone the surgery and arrange for a clinic appointment to discuss it further. The patient's daughter later told the HDC that she was with her mother at the hospital that day and was present for the discussion with the doctor. On that morning, her mother was still very hesitant and having doubts about the procedure. The daughter also noted that on the morning of the operation, Dr. Donaldson told the patient they could change the date of the procedure if she wasn't happy. But the patient said, "Well, we're here now. In other words, let's proceed." The daughter did acknowledge that her mother had no questions at the time, but said that her mother had only had an hour to think about the information given by the doctor. The operation itself was uneventful. Unfortunately, the post-op course was not. The patient developed urosepsis and was readmitted a number of times for this. Eventually, she was diagnosed with osteomyelitis of the pubic bone, an extremely rare complication of the MES procedure. A subsequent stormy course followed where the patient was in and out of hospital. And sadly, the patient finally succumbed to the infection and passed away. It was at that point that her daughter complained to the HDC. So I'm thinking about this case, Tim, I'm going to ask you, with regards to the consent, what do you think was done right?
Well, from the sounds of things, a number of things were done right. First of all, there'd been quite a long lead up to before the final clinic appointment where the decision was made to go ahead with surgery. So other options had been discussed prior to that time. At that appointment, Dr. Clark mentioned the significant potential side effects, but also, according to him, gave a pamphlet which outlined a few other potential problems that might arise from the surgery. So that bit all seems to be pretty good. Dr. Donaldson also talked with patient about some additional risks and documented that he'd done that and that she'd agreed and had no further questions. And was happy to go ahead with the surgery. So, I think all of those things were done well.
I'd agree. I think a lot of things were done really well. But I'm presuming that some things could have been done better. Lucy, what do you think could have been improved on?
Well, I actually have to say I agree with Tim that I think a lot of things were done right. I mean, the patient was consented, the common possible complications were discussed, and the patient was given the information sheet. I think it would have been really helpful if the doctor had actually documented that he'd given her the information sheet and that he'd discussed the complications as listed in the information sheet and given the patient opportunity to ask questions, or documented that he had given her some way of asking questions at a later date. One of the problems here as well was that gap between when the consent form was signed in outpatients and when the patient actually came forward to have the surgery, and that there wasn't communication for quite a long period. And I think, look, we all know that that's how medicine works, and that most DHBs would be in a very similar situation where there's often one doctor in outpatients doing the consent and another doctor doing the procedure. And that the process of consent, which involves both those doctors, is often not necessarily very well documented. So I think if one thing that could have been done better is probably that documentation, giving the information sheet and documenting that you've given it. In an ideal world, the patient would have been given an opportunity maybe a week before or the day before surgery to ask any questions that they had. An hour before surgery, as the daughter points out, isn't a conducive time for the patient to feel that they've got time to make a decision. But I think this patient had made a decision 5 months earlier, and it was only a confirmation of that decision. But as I say, in an ideal world, actually having some time to talk to the patient, maybe in the day before or the morning before surgery, would have been useful.
Because the problem here wasn't it, that it was Dr. Donaldson gave additional information in that hour before. And you've got to think, what do you like at the hour before you have major surgery? Actually, your brain's not really functioning particularly well. So to then say that she really did give informed consent to that new information that was given to her, I think that gets a little more arguable.
And I think this is a very common scenario where consent gets criticised, is this consenting in the preoperative area. And there's the additional issue often that the patient's been given a pre-med. And actually then you can talk about whether or not they're competent at that point. I don't have any information in this case whether or not the patient had a pre-med prior to this procedure, but I think that is a particular risk if you're giving the patient additional information or asking for consent for additional procedures, or even discussing anything of significance to someone who's already been given a pre-med. I think you're likely to be criticised by the HDC.
I well remember after having pethidine as a pre-med, deciding that the anaesthetist who was about to put me to sleep wasn't a doctor at all. He was a complete fraud. But I was quite happy for him to go ahead, despite the fact that I knew he was a fraud. Fascinating what
a pre-med can do. So I think the problem is this is such a common scenario, that consenting in that hour or in the preoperative area, getting the patient to. I've had cases where the patient signed their consent form literally minutes before they've gone into theatre. And I think that does put our clinicians at risk, because actually saying whether or not a patient has had a chance to actually weigh up the pros and cons of a procedure when they're already, in a hospital gown on a trolley and just about to be wheeled in is not really, you haven't got a very strong case to say that you've given them sufficient time to weigh up that decision.
No, that's right. And as you say, though, it's really common practice. And I guess because of the pressure on the DHBs and beds, etc., they can't bring them in the day before. They often do bring them in on the morning. And it's just less than ideal that a surgeon gets to meet their patient for probably what is 5, maybe 10 minutes if you're lucky, just before a procedure. So they're entirely reliant, aren't they, on the clinicians that have seen the patient before and the process that has been followed. And so I think that the surgeons themselves are quite at risk here.
And you have to bear in mind as well that the HDC does use other surgeons to give expert opinions in these cases as to whether or not the care provided was reasonable. And those other surgeons will also be working in DHBs that have less than ideal circumstances as well. So I think often your colleagues may think, actually, in the real world, this is often what happens. But in the cold light of day, when there's been an adverse outcome, it's just very easy to criticise.
It is, unfortunately. And obviously, I think we need to do another podcast simply on how to be an expert witness for the HDC. But you're right, often they are very critical. And it's easy to approach a case with hindsight bias.
Another thing that comes up here, even though it wasn't in this case, is where junior staff are doing the consenting process. And if they're junior enough, they actually may have no real idea of what the operation really does entail, and what the risks really might be. And, is that sufficient to give a patient the information they need to give informed consent? That's arguable as well.
I've certainly heard of junior doctors who've called in MPS asking for advice, saying that they've been asked to consent patients for procedures which they really aren't equipped to do. And I think that's an unreasonable thing. And I know it's hard as a house officer to push back when your SMO has said, no, you need to go and consent that patient. But I think it's important that they push back in some way. And I would have thought, in fact, the DHB would have a policy around that to protect their junior staff. But it's certainly fraught. The consent process is really fraught, isn't it? So based upon what Dr. Clark had documented in the consent form, with limited number of possible complications, the HDC expert was critical. However, Dr. Clark was not held responsible for the consent of the patient, as she was not the operating surgeon. The HDC expert was critical of Dr. Donaldson as the operating surgeon for discussing the risks an hour prior to the procedure. The expert, however, correctly, I think, placed the blame on the DHB for the system that Dr. Donaldson worked in. Therefore, the HDC wasn't critical, ultimately, of Dr. Donaldson and acknowledged that he was placed in a very difficult position. And I think that's good news for the proceduralists who are listening to this podcast, in that because of the system that you work in, and the fact is you can't bring the patient in the day before or several hours prior to their procedure, that's taken into account should there be an issue following the case. So the learning points you can take from this particular case: it's important to document the information provided to the patient in enough detail to confirm what was discussed. It doesn't need to be a transcript of the conversation, but it does need to have enough keywords in there so that everybody's aware of what you discussed with the patient. Using patient information pamphlets is really useful, and it's also important, though, to document that it has been given to the patient. Another learning point is to provide an opportunity on another occasion for further discussion, even if it is by phone, with regards to this consent process. I know that it's very hard to do that and not always possible, but in the ideal situation, that is what would happen. If you are the operating surgeon, you do carry the greater responsibility. And the final learning point is consent conversations need to be had well ahead of the procedure if you can. And in this particular case, the conversation was had 5 months prior to the procedure, which was great. I think that another couple of conversations, of course, would have helped, but that just isn't very practical in the hospital system. But giving the patient enough time to absorb the information, think about what questions they want to ask, and then come back to you again is ideal. We've talked about 2 really interesting cases around consent. The fact that you need to provide explicit consent for any variation in the operation that you want to do. Otherwise, you need to not proceed and wait till the patient wakes up and re-consent them. And we've also talked about forewarned is forearmed, and talking about the sad case of this patient who had a mesh operation which ended very badly. We know that consent is a real sticking point when it comes to HDC complaints. We hope that you've learnt some really helpful tips today, and hope that you'll join us again for our next podcast. Thanks, Lucy and Tim, for joining me today.
Thanks, Sam. It's been a pleasure.
Pleasure, Sam.
Thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review.